Thank you very much for joining us today. We have a great panel to talk to us about care services and the opportunity for IoT-enabled services. We've got a great panel today. One of them will join us as we get started. We have Jane Townson, who's the CEO of UK Homecare Association, who's joining us. Katie Smith Sloan, President and Chief Executive of LeadingAge, will be joining us from the US. Thank you for joining us today. And Paul Oliver from Vida, the Chief Executive of Vida. And frankly, this event could not be better timed in terms of the number of changes that are going on in our lives and the working environment, irrespective of what position that you hold. So let me take a moment to kind of frame the conversation here. It can be quite broad if we're not careful. And so I just want to put it into the perspective of the speakers that we've got here. Our speakers represent organizations that offer care services at home. We may go in the direction of consumer primarily as a background to what is acceptable in a professional setting, but this panel is really strong talent around care services. Care services in the home is an interesting topic in the sense that prior to COVID-19, it was the direction of travel for the government's support for increasing care needs of our increasingly aging population. The US market is a very different market, and our panelist, Katie Smith Sloan, will be able to tell us more about how the US market works. In the UK, IoT in the home was cautiously developing. There was some consumer market behind it, but as service providers cautiously developing solutions, implementations were measured in months and years, not weeks. There were plenty of pilots in different settings. Rollouts were really limited primarily to the true innovators, the early adopters. And then COVID-19 hit. COVID-19 changed all the rules. Many of the big barriers to adoption, particular technology and IoT solutions, have fallen away. Technology is of any sort has been supported for people self-isolating, is very much in demand. And clinicians, NHS clinicians that had historically resisted using technology primarily for remote consultations are now using it. 3 out of 4 consultations, GP consultations, are now remote. I heard a statistic yesterday: out of 1 million consultations across all NHS services, only 10,000 a day were face-to-face. So remote has gone from a sideshow to the main show in a very short period of time. So the question that we'd like to explore with our panelists, and I'd like to welcome Jane to the panel.
Hiya.
Thank you for joining us. I know.
Sorry, I'm late.
No, it's okay. We got some of the logistics out of the background, so it's thank you for joining us. I was just framing the conversation, and in particular, have all of these changes that were happening before COVID-19, and now that COVID-19 has hit. Has it translated into IoT use for clinicians? They're using GP services, but how do you integrate it into clinician services? Can it be used to predict adverse events? What sort of main barriers remain? And the language around all of this stuff, I think, is absolutely fundamental to its adoption. Is it monitoring, or is it empowering to an individual to help them stay independent in their own home for longer? The words that we use and the way that we introduce these concepts, I think, is quite important. So what are the changes that are needed for wider adoption? So what I'm going to do now is ask each speaker to introduce themselves, their organization, and a couple of opening comments on their view of this particular topic. And Jane, I'm going to throw you into the front line right up front. We'll start with you. We'll go to Katie and then Paul. Just who you are, who your organization is, and a little bit of your thoughts on this particular topic. Over to you.
So, hello everybody. I'm Jane Townson, the Chief Executive of the United Kingdom Homecare Association. We represent and support providers of care in people's own homes. We have over 2,000 members representing very small to very large providers, predominantly state funded and predominantly private pay funded, and every mixture in between. Also, general sort of mobile domiciliary care providers and more specialist providers such as live-in care, housing with care. And I am on the National Adult Social Care COVID-19 Planning Group, which includes people from NHS England, Public Health England, CQC, local authorities, every kind of body that you can think of, MHCLG, involved in thinking about the pandemic, but also with a mind to thinking about the future as well. And that national group has a number of work streams underneath it on things like personal protective equipment, testing, workforce, provider funding, and all kinds of things. Part of the work is involving NHSX and its work streams, and there's a huge amount of work going on a whole range of different areas. So there's a clinical cell, they call them, a connectivity cell, getting deliveries of things to people like food and medicines. There's a whole range of different things. And at the moment, I would say most of the focus is on care homes, which I do keep protesting about. However, as everybody knows from the media, the care homes are having a really tough time at the moment, and clinical support has been generally inadequate for them right from the beginning. So helping them get devices in and also some basic infrastructure too, because that's a real issue. Quite a number don't even have Wi-Fi properly installed, and if they do, it's not sufficient levels of data security for the care records, and having a separate area for visitors and things. So to home care, I think what this pandemic has shown is how valuable it would be to have more technology, and there are a number of reasons for that. First of all, people themselves are isolated at home, often cut off from their loved ones, so being able to keep in touch, that works both ways. Families are really worried about their loved ones, and I'm sure we're all experiencing this. And then there's the health monitoring, because the people who are particularly at risk, the shielded people and so on, they're shielded because of their health conditions. And what we're seeing is quite a substantial number of people cancelling their care calls and not seeking medical help when they need it, because they're afraid of going to the hospital, they're afraid of catching COVID-19, and they're afraid of being a burden to the NHS. So the need for technology to help monitor their health and just keep an eye on them. Other areas that I'm interested in are the palliative and end-of-life care, because again, community health services don't seem to be as available as they have been. I'm really worried about people having to verify death maybe, or know how to care for people at the end of life, and to have somebody on the end of a television screen or an iPad or something just to talk them through it would be hugely encouraging. And then the practical things about ordering food and medicines and those kind of things, they're all things that are desperately needed now, really. So there's a lot of work going on to try and roll things out in care homes, but not so much yet in the home environment.
That's great, Jane. Thank you very much. There's a lot to unpick there. We're going to get a U.S. perspective now with Katie Smith Sloan. Would you very kindly introduce your organization and your opening comments, please?
Sure, thank you. Thanks, Eric. Nice to meet you, Jane and Paul. So yes, I'm Katie Smith-Sloan, and I am the chief executive of an organization called LeadingAge in the US. So we are a membership organization of 5,500 not-for-profit providers. So it's home care, home health, hospice, nursing homes or care homes, affordable housing, adult day. It's really the gamut, assisted living, continuing care of providers of services for older adults, and many of them provide lots of different kinds of services, not just one. I think our experience in the US with COVID is very much mirrors yours in the UK. I think the care homes are having a really hard time containing the virus once it gets in. And from what we can tell so far, based on kind of the data that's available to us, the more staff the care home has, the bigger it is, with the more staff coming and going, the more prevalent COVID is in that community. And sadly, lives are being lost, both for staff and residents, working hard to at containment through, infection control and proper PPE, adequate PPE and testing. But it's a challenge all the way around. One of the perhaps bright lights in all of this is that telehealth is now being supported by our government in terms of reimbursement, and it's becoming more available. I would say we have a ways to go in with the older population, with our home health agencies and whatnot, because the government still will not pay for a telehealth home health visit. And like Jane, we are seeing the number of clients go up, but the number of visits go way down. People are afraid to have care workers come into their homes. They're afraid of infection, so they're canceling visits with a troubling frequency. So I think, the opportunity to normalize telehealth and figure out how to do it well is a great opportunity for us. We've taken some of the mystery out of it, I think, because of we've jumped into this with COVID, and now I think we need to figure out how to do it well and how to make sure it's not just virtual visiting, but actual delivery of home health care.
And your point about reimbursement is an excellent one. We'll come back to that one. We'll give Paul a chance to introduce his organization, who embraces technology in a very big way. Paul, over to you.
Hi, I'm Paul Oliver, Chief Executive of Vida. We're based in London. Vida started out as a pure technology company trying to develop technology for the domiciliary care. And what it learned, like all its peers, was actually you need to understand care and the people that you care for, and you need to care for them as well. And so we extended out into providing domiciliary care. So we're regulated under the CQC. And what we've found is that the barriers to adoption of technology have actually been in the service providers. There's a huge demand for technology in the people who are commissioning care, the local authorities, for example, or in the private sector. The commissioners of care tends to be the children of the people that we're caring for. And of course, that generation are now tech savvy. We have technology in our consumer lives. So the barrier to adoption has mostly been in the service providers. In the UK, it's predominantly a paper-based administration system. So COVID-19 has been great because, as Katie said, it's just pushed everybody into the realization that technology can work, and it's not a bad thing. So an example of this is that before COVID-19, the written wisdom was that you could only operate domiciliary care with having your operational staff together in one room on a site. We now run our care agency with everybody working remotely. And in fact, the quality of our administration has gone up because of that. So we've found, though, that in the development of technology into care, it's a very long process because you can't do the consumer model of just throwing something out there quickly and apologizing if it goes wrong. Of course, right? We're caring for individual people, and they are the most important people.
Thank you, Paul. For as much as this is about IoT, really care services are around personal contact. I love the panel's view on how technology can better enable human-to-human interaction, making a better quality of interaction. Maybe I'll start with you, Paul. Given sort of, we'll work the opposite way. From your perspective, how can technology be implemented to improve the quality of the human interaction, not technology for the sake of technology?
I think that the key thing is transparency about the efficacy of care. Up until now, if you're a receiver of care or you're a commissioner of care or next of kin, you have absolutely no insight into how effective the care that is being provided is. And you have very, very little insight into the rationale for the care and for the direction of travel. Is this taking the client, the person you're caring for, in the right direction? And the other thing about it is that there's just very little consideration for the mental well-being, right? And the general health of the general well-being of the person you're caring for. So that's where technology comes in. It allows you to share these insights with all sorts of different audiences in a way that, for example, meets privacy requirements and stuff. So the natural byproduct of technology can be transparency.
Katie, from your perspective, sorry, I was on mute. I'll hand over to Katie at this point. Katie, what are you seeing on your side in terms of implementation of technology for better human interaction?
Yeah, well, I think what's one of the things that's been interesting about watching this telehealth world unfold through COVID is that it's as big a learning curve for practitioners as it is for the care recipient. And what my experience is, my husband had a couple of telehealth visits since we've been, sheltering in place here, is that the practitioners themselves have to try to humanize that experience. It's really, the burden is on them to recognize there is a screen between them and their patient, their client, the individual they're serving. A few minutes of let's get to know you, a few minutes of how is to Paul's point about the mental well-being of people right now is just something I'm deeply worried about. But I think we need to make sure practitioners don't put all the burden on the recipient, but the practitioners are doing a good job of humanizing that experience.
That's a great point. Jane, you have a unique experience. You're trained as a clinician, if I understand correctly. You have background in residential care, and now you're focused on care in the home. You have a broad spectrum. What do you see from that breadth of experience?
You're on mute.
Sorry, I'm on mute. I was on mute. Yeah, from a technology perspective, there's sort of technology to support care workers, technology to support citizens, and technology to support care providers. And some solutions kind of overlap all three. In the UK, roughly 30% of providers are using technology to support their care operations. So they're using digital rostering and digital care planning systems. And those providers are finding the most resilience during this crisis. I think with regard to sort of technology solutions for citizens, a lot of that's been driven up to now by local authorities here, local government, sort of telecare people. And some of the solutions, in my view, are rather old-fashioned, sort of still using old analog type systems. And the Internet of Things solutions, the issue I see there is that there are loads of gadgets, but your average citizen hasn't got a clue how to string them all together and make use of them. So the suppliers that manage to do that in the simplest way possible and give really good customer service, I think will do very well. The health service is learning very fast how to make use of these tools, because they've had to. I mean, that there have been various pilots in the past, but they've never really sort of caught on, I would say. But now they've really got no choice. And I think this situation with COVID-19 isn't going to go away in a hurry, is it? So I think it could be at least another 2 years, even assuming anyone can come up with a vaccine. I think that we will see quite substantial change over time. But at the moment, I would say that it's still not. I mean, that the council, the local government sort of assistive technology people, they have had trouble keeping going during the crisis, because they've been reporting 35% staff absence themselves, with the monitoring devices. And those monitoring devices, the way they're currently set up, rely on services being available to go and help. Well, that hasn't always been possible, and we've had a real problem with inadequate amounts of personal protective equipment available too. So I think there are some issues that have got to be addressed in terms of how you service these things. Because, if you find that Mr. Jones has had a fall, so what? If no one can go and pick him up, it's not much help, is it?
Yeah, no, that's right. Yeah, no, and I think that's a great point. There's data, and then there's the so what of the data. How do we make sense of all of this? And that's actually kind of where I wanted to take some of part of the next conversation, which is that, it's nice to collect some of this data. What are your organizations collecting? What is of interest? And, where is it in the spectrum? Is it just about making decisions, or are we actually getting to a point where we can predict things? Katie, what are you seeing from your perspective, please?
I think there's just tremendous opportunity. What I see is I think we're in our infancy here with using data to identify trends, to detect early signs of change or predictions about decline or issues that can arise. But I think that once we're able to use data to validate it, make sure that it's clean and accurate, it's going to provide just incredibly powerful insights and predictions to prevent both preventative as well as predictive care. And I think that's where we need to go.
No, that's right. Let me go back to Jane, and I'll come back to you, Paul, on the same topic. So Jane, what is the so what of the data? So instead of reacting to a fall, how can we predict a fall? Is that anywhere on the radar at the moment, or are we still too early days for any of that stuff in your membership?
I mean, well, I don't know that anyone's doing that. I mean, in the immediate term with COVID-19, what I'm pushing for is that there's more monitoring of vital signs and physiological monitoring. So one of the things that's been noticed is that there is this phenomenon known as silent hypoxia, whereby people's oxygen saturation levels fall to dangerously low levels before they start to feel breathless. And by the time they feel breathless, they're definitely a hospital ventilator case in many situations. But if you can detect those falling oxygen levels early, then sometimes just a bit of a oxygen mask within 15 minutes, people can perk up, and then you avoid the whole terrible ICU situation.
Yeah.
So, in care homes, for example, the British Geriatric Society have recommended, pulse oximetry, heart rate monitoring, respiratory rate monitoring. So why would we not do that in home care? And so we can, detect early people and get mobile oxygen to them, or whatever else, and similarly with things like diabetes and all of that. So I think there's a preventative thing. I think that what may happen with some of this monitoring, though, is that we will start noticing things that we didn't notice before, and not necessarily reduce pressure on the health services, but increase it, because we'll start to see people's deterioration. I mean, that's not necessarily a bad thing, because it may be that you can intervene earlier with some less expensive, complicated intervention than waiting until somebody, has to be blue lighted. Yeah. But it comes back to, equipping people to do that. And the care workers, for example, there's a lot of things that they could do. So just teaching them how to do urine dip tests. It's not that they're there to diagnose, but when they phone a GP and ask for help, they've actually got some data that they can give to the GP, so that they're not just saying, "Oh, Mrs. Jones looks a bit peaky today and I'm worried." They're saying, I've done this dip test, I've measured her blood pressure, I've measured her respiratory rate, these are the data, this isn't normal for Mrs. Jones. And then that will give the doctor more confidence to do something quickly, rather than just say, "I'll keep an eye on her for another few days."
Well, I want to come back to that point. You've raised a really interesting point that I think is worth circling back to in terms of prevention versus the prediction and early intervention, because there's a question where NHS spends its money and other, how that's allocated. But let me come to Paul and get his feedback on the question we were just talking about. What's the so what of the data? What are you recording and what are you doing with it?
I mean, data in itself has absolutely no value at all, right? It's what are you using it to, what service are you trying to achieve by, in this case, collecting data and analyzing it? I mean, I think that Jane has just been talking about the strategy that we're pursuing, right? It's all about predicting when someone is going to become ill, and can you act early enough to prevent them becoming ill? I mean, we know in domiciliary care that the vast majority of causes of someone leaving their own home being cared for in a residential setting, it's be triggered by a set of known health events. And all of these health events have a period of time before them where, if you take action early enough, like for example, ask for a clinical diagnosis, then you can stop that disease or accident happening. So we think that, I think the key thing is that you're not trying to make a clinical decision yourself. As it's said, you need to bring the clinician and the person you're caring for together at the right point in time before that health event happens. And absolutely, that's the role of the carers, right? The carers are there routinely and they're able to collect additional information, such as doing a urine test or temperature test for UTIs, for example, is the other one and stuff. So,
okay, great. Katie, how is it in the U.S. with the clinicians' acceptance of this data? So Paul was just talking about the data that comes from these devices, but are clinicians willing to use it? How do they trust it?
Yeah, I think it's a great question, and I think they trust it when they're part of the, they're involved from the conceptual stage, in the design, the building, the validation, verification, testing of the predictive models, and any decision support capabilities associated with them that leverage those models. But when so I think that being part of the creation adds to the acceptability of it, because then they realize that actually it is going to be helpful to them in terms of working with their client, resident, patient population. But if you leave them out of that process, I think it's it's, sort of give them a ta-da, here it is.
Yeah.
Use it. I
Yeah.
think that's,
And it gives them more work, as Jane was
disadvantage.
saying.
Yeah.
Yeah. How's it being used in your membership? Just following up on that, if I may, please.
So I would say, it's various places. The more sophisticated members have invested a lot in technology. There's a lot of investment in fall prevention and detection technologies. I think that's sort of, in many ways, I wouldn't say the easy, because I'm not a technologist, but it is a very obvious place focus for technology because of the health costs and impact as a result of falls. So I would say there's a lot of acceptance there. And I'd say, to Jane's point too, that sort of the infrastructure of technology in aged care organizations, whether it's a home health agency or a care home, has become far more sophisticated. I think that the question is, how do we help them figure out how to use the data that they're collecting? They're sitting on a gold mine. How do we help them use that to deliver better care, to understand their resident and client population better? And I don't think we've done a good job yet of sort of helping that in that translation process.
Jane, on that point, in your organization, how are you helping the members use data well or make sense of it? What's happening from your perspective, please?
Well, one of the things I was going to say, actually, following a comment that Paul made, is I think one of the big barriers to wider spread adoption is the way that home care is purchased in the UK. So 70% of it's still purchased by local authorities, and they don't commission on outcomes. So Paul mentioned no one's measuring outcomes. Well, it's because they're not asking for it. They're not even thinking of it. They just pay for 15-minute visits or 30-minute visits if you're lucky, or in the worst case is paying by minute. So it's very task orientated, and I think there's a kind of commercial issue really about the business model, because if you do these interventions in home care, where you're most probably saving money is further downstream or upstream, downstream in the health service. And so some of our members have installed some of this technology in their clients' homes, the ones that are paying for themselves, but they haven't figured out how to generate a return on investment. Mm-hmm. And until they're doing it at the moment for a kind of marketing advantage almost, like we can offer this service so your loved ones will know what's going on and so on. But in terms of actually any financial benefit from it, no one's figured out how to do that yet. Yeah. So I do think that's a real issue, and I think maybe in the American system it could be rather different, because you're quite insurance driven, and some of the larger sort of organizations like Kaiser Permanente, they're thinking in system terms, the kind of the accountable care system type approach, so that you're looking at the collective costs for an individual, not just the different silos. Mm-hmm. So but to your question, I think we're just trying to get everybody off first base, because getting as many people as possible using technology solutions for care records. I mean, it's transformational, because like Paul said, you can suddenly see in real time what's going on in every visit, and you can see where your care workers are, and you can figure out how to manage their time more efficiently and things. And once you've got some of that base technology there, then it becomes easier to start introducing other things. So I think it's already accelerating. But the financial position at the moment, due to COVID-19, is going to make it really hard for people even to think about investing anything, though. Yeah. We're going to see multiple provider failure if we don't manage to get some more money to them all pretty quick. Yeah. So I think we're seeing a bit later on today, in fact, it's a different company, but there's all sorts of really clever things going on. So natural language processing tools, which are actually being used in day to day now in care homes in Finland and things, to sort of be able to analyze the written record as well as sort of numbers in fields. Yeah. And I think, like you said, there's just a massive richness of data that Katie said that we're sitting on and not doing anything with.
Yeah.
So it's trying to connect people, and we're running sort of events showing them what's available. But a lot of them, the 80% of the market is small businesses with fewer than 50 employees. And many of them just don't have the skills to know how to procure an IT solution. They don't know what to look for. And they go to the health and care shows, and there's like 150 stands with gizmos all appearing to do the same thing. So, what do you do? And if at the moment they think, oh, my costs are only, £10,000 a year from having this, cronky old server in the corner. But if I go to digital solutions, it's going to cost me $100,000 a year. Why should I do it? So it's quite a challenge, I think.
Sure, I agree. Paul, let's give you a chance to respond to that.
Yeah, so I think there's a key point there is the UK market, as Jane says, is highly fragmented, and actually most of the care providers are very small entities who can't afford to build their own technology or commission their own technology and expect a return on investment straight away. So the answer to that lies in building a platform that allows people like the smaller providers to use some of your technology, for example, predictive analytics, but at a very, very, very low cost, right? So you're not trying to get all of the profit out of every single person who uses your service. You try and spread that cost over the whole market of your customers. Because if you don't do that, you end up with very, very poor adoption across the market as a whole. I think Jane's point about the cost, the benefits of improving care in the home is siloed. That's very true. But what we're seeing though, of course, is the structure of the UK market. Local authorities are also responsible for paying for the care of someone who then goes on into a residential home. And that's about 3 times the price, roughly, of being cared for in their own home. And so there is a growing demand among local authorities to reduce the total cost of care per individual that they care for. But it's a fine balance. I mean, certainly you can't be charging the same margins as consumer technology, because as we all know, there simply is not that money invested in the care of individual people.
And so I wanted to bring in the language to this. Paul, let's start with you, and we'll go across the other panelists. From a perspective of getting this into the home, Jane was talking about almost a marketing side of this. I've worked with IoT providers in the past, and they said, oh, well, this will be great because the adult children will get to monitor their parents. And what they found was that wasn't the benefit. It was actually empowering to the individual. The language that we use here is quite important. Do you want to comment on that?
Yeah, I mean, my view is technology is only ever going to be an enabler. It's never the end goal itself. So the idea of monitoring, I personally don't like that at all either, right? You're absolutely right. It's what are the benefits? And the benefits change for individual people, whether you're being cared for, or whether you're the next of kin, or you're the payee of the service. And so the language one needs to use needs to be tailored to those individual people. And I would even argue that the language you need to use changes across other factors like socio-demographic factors as well.
Yeah. Katie, the U.S. market is a very different market. We see lots of fancy gadgets with lights and bells and whistles over there. What are your customers? You've got service providers. What are their customers wanting?
So I would say, we have something called the Center for Aging Services Technologies that we started about 10 years ago at LeadingAge, and it is really meant to be a platform for providers, technology companies, and researchers to come together to really try to augment this field of technology and aging services. And one of the things that we've done over the years is to try to take the mystery for our provider members out of making those kinds of technology decisions, those investments in technology, and trying to encourage them to look at it as an investment rather than an expense. So, for example, looking at medication management technologies, there are a lot on the market. What we've done, our team has done, is said, as a provider, what are the things that I need to think about when I purchase a medication management? What are the elements? And then we've matched those up against the products that are on the market. We're not rating them. We're not a consumer report saying what's good or bad. We're simply saying these are the attributes of these various technologies to create, so it's a decision tool really for our provider members. So we've done that on fall protection, fall prevention, medication management. We've got 12 different areas, social connectedness, technologies, because we feel as if it's part of our job as a membership association is to try to help our members make good business decisions about technologies and to bring those technologies to them.
No, that's a great point. Jane, from your perspective, I'd love to get a comment. In the care home industry, we saw some providers who were implementing tech, and there were lots of tours through those service providers who had all of this tech, and they said, well, whatever they're doing, I want to do too. Is that happening in the domiciliary care market?
In terms of Internet of Things,
sharing of information across your members. You were talking about the problem that your members have making sense of this. They're small organizations, 150 with all sorts of bells and whistles. How do you make sense of this? They're afraid of making wrong decisions. It's a big cost. In the care home industry, I saw them following the leaders. There were people who were leading with technology. Is that happening in the dom care industry?
I think it is, yes. And we did an event just before Christmas on digital solutions for home care. We had a number of providers speaking about their choice to go digital and what they had, how they had found that, what lessons they learned. Because I think actually providers talking to other providers is a far better way of promoting technology than having the technology companies themselves saying it. And some of them, some of the outstanding providers are also, as I said, sort of introducing some of the monitoring gizmos and things. But I think, and a number of them have stood up publicly and said, we would never have achieved our outstanding rating if we hadn't done this. So I think that you will get that effect of people wanting to follow others. And we've got a group called Digital Social Care, which is, we get a bit of money from the Department of Health and Social Care, and that enables us to help with some of the wider issues, because we're finding that there's just a massive lack of understanding of even GDPR and data security and data protection. It's quite hair-raising, actually. So some of those foundation pieces that need to be done, and other things like in domiciliary care, use of mobile phones. So some providers, for example, are expecting their care workers to use their own mobile phones rather than company ones. And then you've got no mobile data management system and all of those kind of issues. But a lot of them we're finding just don't understand the issues around data security and all of that. So there's a massive... can you still see me? Sorry, I just came in and my screen went blank. There's a massive amount of work to do to educate people, and the ones that have adopted technology first, they're often people that have come from other sectors into home care and know from other walks of life how valuable it can be. One of the limiting factors originally, there weren't any decent products. I mean, in my previous organisation, we would have gone digital 15 years ago in home care if there'd been anything there. But the first products didn't really come into the UK market until 2015 sort of time, So, So what we're trying to do is help people understand what's out there and provide them with some help in making those decisions.
Yep. No, that's great. I'm conscious of people's time. I think we're coming close. I wanted to give each of the speakers just a chance for any final closing comments. Paul, we'll start with you.
I think the future is in IoT, and it's about enabling the delivery of better care to increase the quality of people's lives.
That's great. Thank you very much. Katie, from your perspective, please.
Yeah, I would say I think we need to take advantage of the moment that we're in to really learn from this experience. I think my wishes for the way going forward are that we really focus on user-centered design, that we really focus on interoperability, and that we articulate the outcomes that we're going to achieve through the use of technology.
No, that's fantastic. And very to the point as well, which brings us back to Jane. Jane, any closing comments, please?
I'm personally very excited about the opportunities for the future, and particularly improving transparency, efficiency, and quality. But I think we all need to remember that care is fundamentally a human interaction, and as Paul I think said, technology will never replace, it just augments and potentially enables care workers to spend their time doing what they're best at, which is forming relationships and supporting people with their emotional well-being as much as their physical, addressing their physical needs.
That's fantastic. And just to add my final comment on all of that, it's absolutely fascinating to hear from the front line. We're living in an unprecedented times, which I'm sure you've heard before. But as Katie was saying, it's time to take advantage and come out better than we did, or move things along, learn from the experience that we've got here. We've got an opportunity to really leverage barriers coming down, both on the demand side, our service users, and the service providers are being forced to use it. Clinicians are now forced to use it, not wanting to have the face-to-face and risk disease transmission. Katie, very interesting, said it's still early stages. Jane was talking about the very basics that would need to be implemented here. But there is an opportunity to provide better quality care, and as you just said, Jane, focus on the human interaction and technology to enable what carers do best. So I'd like to take this opportunity to thank our speakers and thank everyone for coming to today's panel. That's all that we have from our perspective. So thank you very much.
Thank you, Eric.
Thank you. Thanks, Eric.